Today to talk about some of the work that our team is doing in two contexts, in the Bronx in New York, and then also in Togo, West Africa. First, I just want to start out by acknowledging my team. None of this work is done alone, and we have a large team of people both here on the US side and also in West Africa working on these projects, which means a whole lot of Zoom calls and collaborative meetings. And so I want to acknowledge all of them, especially including our community health workers, who you're going to hear about a lot today in Togo and in the Bronx. And so here's our agenda for today. We're going to talk about assessing context and why I think it's so important to do that. Going to talk about community health worker models briefly, and then I'm going to talk about the two different contexts in which we work in Togo with an NGO called Integrate Health, and in the Bronx with the Community Health Worker Institute. And then I'm going to end with just some thoughts on context and generalizability and where I think this research could be headed next. So in terms of assessing context, context really is a multidimensional construct that encompasses micro, meso, and macro level determinants that are pre-existing, dynamic, emergent throughout the whole implementation process. I like this definition by Rogers and others. So context represents normal conditions of practice and a team's ability to enact change. And there's really a dynamic relationship between implementation and context. So the role that context plays in moderating effectiveness is often neglected. Like, we tend to focus on interventions that work, but not thinking about the context in which they're being implemented. In particular, research exploring healthcare programs, which is the area in which I work, predominantly neglects the crucial role that context plays in moderating effectiveness. Sometimes we're surprised when an evidence-based intervention doesn't work in our context. This was context and generalizability were the topic of one of the sessions at the D&I conference in December, if any of you were there. And I liked one of the speakers talked about the idea that the intervention itself is the seed and the context is the soil in which we're planting that seed. So we have to think about that soil and where we're planting that intervention. And then thinking about community health worker models, there are various community health worker models that are used throughout the world and also in the US. In low and middle income countries, CHWs often provide community-based primary care services, usually with some kind of focus on maternal and child health, perhaps family planning. In high income countries like in the US, CHWs tend to fulfill non-clinical roles. This might include care navigation, linkage to social services, and education. So just a brief update on the current state of community health workers in the US and globally. So in the global context right now, there's a lot of growing advocacy for salaried, supervised, and supported CHW models. There's new WHO guidelines that have been published and are increasingly being followed by NGOs and governments across the world to make sure that CHWs are paid fairly for the work that they do. And in the US context, there's really this move towards integrating community health workers within healthcare systems, including reimbursement and billable activities. So with the 1115 Medicaid waiver in places like New York and also California, CHWs can perform activities with patients that are now reimbursable by Medicaid. And with the Joint Commission requirements now about social needs assessment, which I'll talk about that a little bit later in the presentation, increasingly CHWs are being activated within healthcare systems to respond to these social needs. So first I'm going to talk about one context in which we work, which is Togo. And in Togo, we're implementing a program that we call the Integrated Primary Care Program. So to start out, a little bit of context about Togo, because you might not know much about it. I didn't know much about it before I started working there. So Togo is a small country in West Africa. It's right there. It's a skinny country between Ghana and Benin. The population is about 8.8 million people. And declines in child mortality across the world have been happening, but in Togo, they're really lagging behind other peer countries. So they're not on track right now to achieve Sustainable Development Goal number 3 That is the goal, that they would have, that a country would have less than 25 deaths, under 5 mortality deaths per 1,000 live births by year 2030. And right now in Togo, the rate is around 60. So that is definitely too high for under 5 mortality. Togo also, oh, and I should say that Togolese children, they continue to die of diseases that have effective and low-cost treatment. So these are all things that are mainly preventable. So malaria, lower respiratory infections, diarrheal diseases, things like that. In Togo, the health system is fragmented. It's largely fee-for-service, and most people access care at local health centers. There are also district hospitals and regional hospitals. But only 30% of the Togolese population report using public facilities for healthcare, and quality measures around the existing services are mixed and largely unknown. I included also on this slide that there's in Togo, there's about 5 doctors per 100,000 people, so not very many physicians across the country. And importantly, about 70% of those doctors are located in Lomé, which is down at the very bottom of the country, right on the water. And the drive from Lomé, there's only one highway in Togo. It goes from north to south. It can take anywhere from 10 to 12 hours to get from the top to the bottom. So access is a major issue. And just so you can picture what kind of context we're working in a little bit more, this is an image of one of our health centers that we work in. This is in the Koutié catchment area, which is in one of the regions that we work. So a little bit about the NGO that we partner with. It's called Integrate Health, or Santé Intégrée in French. In 2004, the NGO was started with a focus just on HIV. In 2015, at the request of the Togolese Ministry of Health, it was expanded to primary care with a focus on children under 5 and women of childbearing age. In 2018, we launched the Integrated Primary Care Program, which consists of evidence-based strategies to provide high-quality primary health care to all. And then from 2018 to 2022, that program, that what we call the IPCP, was expanded to 4 additional districts in the north. The components of the IPCP include, first of all, community health workers, which I'm going to talk a lot about today. Also, clinical capacity building. So we have clinical mentors that work at the with the government-supported health centers, and they help train the staff there in best practices. We also work on supply chain infrastructure. So we train pharmacists that work at those health centers to make sure that they have the medications that are needed. And then we also provide user fee removal. So basically what that means is we provide the health centers with block grants that cover the cost of point of care fees for both pregnant women and children under 5, so that those that can't afford to seek health services can still get their necessary appointments. And so our community health worker intervention in Togo currently has just over 200 CHWs working throughout the region. Our community health workers are recruited from the villages where they will work. They're trained, they're salaried full-time employees, and we use a supportive supervision model with CHW supervisors in charge of small groups or catchment areas in which the CHWs work. Our community health workers do home visits, including treatment and follow-up. We also use proactive case finding, which means our CHWs go from house to house looking for sick kids and malnutrition, not waiting for people to come to the health center. And our CHWs are also integrated with the health center. So if there's a case of serious illness, they refer patients and help provide transportation to get them to the health center. In this picture, this is one of our CHWs, Miriam, and she's carrying out a prenatal consultation in Koutié, which is in the Dongpen district. So after we first rolled out and did primary care in our initial district, which was called Koza, in 2018, Integrate Health launched the expansion into the 4 districts, which I mentioned already. So in order to assess that impact, we proposed an implementation science study. We used a hybrid type 2 effectiveness implementation study, and we did annual measures. This included household surveys, in which we did around 10,000 DHS surveys per year. We did facility assessment. It's in all 25 health centers in which the program is implemented. And we did key informant interviews, which is what I'm going to focus this talk on today. So in terms of data collection, we did in-depth semi-structured interviews with 79 participants, 1 year following launch in each of the 4 districts. So that's we did about 20 in each year. It added up to the 79 total. We developed our interview guides using CFIR, the 2009 version. You may be familiar. It's an implementation determinants framework that can help classify contextual factors that influence implementation of an intervention. Participants were proposively selected, and we included health center staff, district health directors, IPCP staff, so our own staff, CHWs, and community leaders. And our interviews were audio recorded, transcribed, translated to English from either French or Cabier or one of the local languages for analysis. And our team included 2 researchers here in the US, myself and a colleague of mine, and then 2 in Togo. We collected the data and used a team-based rapid qualitative approach to analyze the data. So we're still working on the report and the paper for all 79 interviews, but this paper we did publish using just that first year of data. So this paper was based on the 22 semi-structured interviews that we did in the Basar district, which is the first district in which the program was expanded to. And what we focused on in this paper was what we call qualitative formative evaluation, which is what I want to talk about today, because I think this approach can really help us as implementation scientists think more about context. So qualitative formative evaluation is an implementation-focused approach that identifies the differences between the proposed implementation and what actually occurs, and to characterize the contextual factors that may impact that change. So it helps to answer how and why questions and can be a very efficient way to improve implementation in real time. If any of you have ever worked with an NGO, you would know that the typical research timeline in which we collect data and then we sort of sit on it and then we analyze it and then eventually we publish it is really not fast enough for an NGO to like improve operations and improve delivery of care. And so we really had to figure out a way to do this in real time with them. So on this table, I know it's a little busy, but I'll go through each row on its own. So the implementation focused formative evaluation categories, and these come from Stetler's article in which she really lays out how to do a formative evaluation. And we borrowed these categories from her to classify and categorize our key findings. So in terms of highlighting the actual versus planned interventions, this is an example of one of our key findings. So we found that frequent medication stockouts and a lack of essential medication. So even though this was a core component of our program, medication stockouts were still happening and were a major implementation problem in most of our clinics within this district. Second, in terms of identifying modifiable factors, we identified a low uptake of family planning, largely due to community perceptions and limited access. So the programs team took that information, and what we designed was a male peer educator program to talk to community members and to help influence and change family planning perceptions and to facilitate access to and acceptance of family planning use by women and adolescent girls. For facilitating needing refinements in the implementation, we noticed that health centers were struggling to complete all the additional paperwork that was needed for our program. So these health centers already exist. The NGO doesn't design or build the health center. It's a government-funded health center, but we come in and we bring in additional programs. But that also means that we require additional paperwork and data to be collected. And so we learned through these interviews that amount of paperwork and that additional data collection was a burden on the team. And so in following this study, we've been working with the programs team and the mHealth team to find ways to streamline record keeping and reporting. We're leveraging data already collected by the Ministry of Health in DISH2 and decreasing the burden on health center staff. For enhancing the interpretation of project results, we heard from really everyone that we were interviewing, all the different stakeholder groups, that the analysis and dissemination of research takes too long to be useful. So as a result, our team developed an infrastructure, including the use of rapid qualitative methods with the implementation team so that we can share and discuss our findings more quickly and efficiently and make those real-time changes to the program. And finally, identifying critical details and guidance for taking the program to scale. So we noted that there are contextual differences among the districts and the sites where the IPCP is being implemented. So using qualitative formative evaluation can help to develop tailored intervention components that speak to the specific needs of each community. So even within one district like Basar, sometimes we'll have health centers that, you know, have a site that's very close to Ghana, for example. So they're getting a lot of people crossing the border to use their services. So how does that change the implementation of the intervention there when you have a lot of people coming across the border to seek services? And so those kinds of, in those ways, like qualitative formative eval can help us identify what those needs are. So some of the main lessons learned from this study is that questions that arise during implementation can be answered pragmatically with a relatively small team. There are just really 4 of us that worked on this project over the last few years. And also structure provided by an implementation framework like CFR or another determinants framework can be really helpful in sort of helping to identify those questions and answer them. Health interventions are really proliferating in low and middle income countries, and data on the context-specific effectiveness can be very limited. So I think having a way to ask these questions about implementation as the programs are already going is really important. Secondly, we learned that we were able to identify gaps that were missed in the quantitative data. So that issue about medication stockouts, we were kind of surprised by that because our quantitative data did not show that. We do these facility assessments and it wasn't showing that we were having stockouts. But what we learned once we started hearing that in the interviews and did some more digging, we found out that those assessments are only done once a month. And so it really depends on that day. It's really only telling us that day, are they stocked up with all the medications they need? It's not providing a picture of the whole month or the whole quarter or the whole season. And so this informed how we collect data about medication stockouts and inventory, and helped the team develop a more global perspective of making sure we have medication throughout the whole year. And then finally, one of the lessons we learned was about meaningful interpretation of finding. So able to, the ability to identify actionable steps and using data to improve care delivery. So there's growing recognition that in order to successfully implement and sustain interventions, qualitative and mixed methods approaches are needed because you really need to talk to those stakeholders that are implementing the program and identify the context-specific factors that impact implementation. So I'm about to switch gears and start talking about our other contexts, but I wanted to see if there were any questions first before I do that.
No questions in the chat so far. I encouraged everyone to use that, but let's see if someone wants to unmute.
And that's okay if there aren't, we can hold them for the end. Okay, thank you. All right, so moving to a different context, to the Bronx, and this is work done with an institute that we call the Community Health Worker Institute. So a little orientation to the Bronx and Bronx County. So the Bronx has about 1.3 million residents. It is the poorest county in the US. 75% of Bronx residents are Medicaid recipients. And in that context, we work with a health system called Montefiore. The Montefiore Health System has an agreement with Albert Einstein, and it's a combined system, academic and healthcare system. So in Monte, we have 11 hospitals, 68 primary care sites, and 73 specialty care sites. The map that you see here, all these little sites on it, these are all the locations Montefiore locations in which we have a CHW currently working. So there are a lot more Monty sites than this, but this is so far the extent to which we've expanded our program. So a little bit about the Community Health Worker Institute. So in 2017, Montefiore Health System began screening for health-related social needs. So a health-related social need, if you're not familiar, it's a self-reported individual experience of social risk factors at a particular moment in time. So this could include housing stability, food security, or transportation access. Health-related social needs are distinct but related to social determinants of health. So social determinants of health would be defined by the WHO as like the larger conditions in which people are born, grow, work, live, and age, and all of the wider sets of forces that are shaping daily life. So we screen for health-related social needs because they're at the individual or family level. So since 2017, we have screened over 250,000 patients at Montefiore. Just between January and April of this year, we've screened more than 58,000 patients. And on the image on the right here is the screener that we use. So this is adapted from the Health Leads social needs screening tool. And basically these questions are asked of any patient that comes into a Monty facility. And that could be inpatient, outpatient, emergency. Whenever they come into an appointment, they get this. And the goal is for us to screen each patient at least annually. So as you can see, the questions ask about housing security, housing quality, food security, transportation, childcare, things like that. But of course, we know that just asking about social needs doesn't actually do anything to improve people's situations. So our approach at Montefiore has been to use a community health worker model to help connect patients with social services throughout the Bronx. So in 2022, we launched the Community Health Worker Institute, and we integrated CHWs within the health system to do this part of the work. So our CHWs, right now we have 25 in the system. By the end of this calendar year, that number will be closer to 40. Our community health workers are recruited from the neighborhoods in which they'll work. They are trained, salaried full-time, and we use a supportive supervision model. You'll notice that that's exactly the same thing that we're doing in Togo. Both of these programs were developed and designed by our executive director, who was a founder of the NGO and also the founder of the Community Health Worker Institute. So this is really the model that we use throughout, is making sure that our community health workers are trained, salaried, and supported in a way in which they can be super effective in their roles. So our CHWs work in outpatient, inpatient, specialty care sites, and also the cancer center. They support patients to access social services through our network of more than 30 community-based organizations, and they integrate social and medical care. This picture is of one of our CHWs, Damaris Flores, and she's meeting with one of our residents in the Bronx to talk about transportation options for medical appointments. So this is just to describe sort of the workflow of what our institute does. So as I mentioned, if a patient attends any appointment or is admitted inpatient at any Monty facility, they then are administered the screener. They or their family, for example, for a pediatric patient, will complete the 9-item health-related social needs screener that you saw on the previous slide. Then if a social need is identified, a flag goes up in Epic, and the provider will then ask the patient if they would like to be connected to a community health worker for assistance, and then they place a referral that goes directly to the CHW. Following that, the CHW contacts the patient to schedule an initial phone or in-person appointment. So we just recently published this paper. This was using REAIM to look at our 1-year outcomes since the Community Health Worker Institute was launched. So this went from like October of 2022 to September of 2023. So during that time period, 17% of our patients that were screened reported one or more unmet health-related social need. That's about, that's comparable to what other groups like the Siren Network and others that are doing regular health-related social needs screening, that's about what we see. Of those that were referred to a CHW, 78.1% of our patients reported that they did receive the social service that they needed. So for example, if they had a food need, they reported back to us that they did get that need taken care of. So that could have been the CHW helped them apply for SNAP benefits or WIC, or maybe referred them to local food pantries. It all depends on sort of their eligibility criteria and what's available in the areas that they are. But what was sort of concerning and what stood out to us is that of those with a social need, only 22.2% were referred. So that means that a lot of our patients that do have social needs are not getting through that step of being referred to a CHW. And the variability was huge. So this study focused on 10 of our outpatient care sites. And some of those clinics only had 3.7% referred, and some had like 68.7%. So there's a huge range in the rate of referral across our different sites. So if we go back to this workflow, we see this third step where the provider is referring the patient to a CHW. This is really where patients are falling off. And so the data was telling us that the drop-off is in the third step. And I should say, before we get too worried about that 22%, there are multiple reasons for not placing the referral. So we think it's really important that the referral is not just automatic, that there's consent from the patient to be referred to a CHW. So the provider has to ask the patient if they would like to be connected to a CHW. And quite a few patients say no. And there's a variety of reasons they might do that. That's like a whole nother project that we're looking into, but they might already have that need resolved or might already be working on it. They might already be on the list for a housing subsidy. So they might have the need and it's not resolved, but they're already working on it. So some people already say no and they refuse, but we also think that 22.2% is too low in terms of referral. So we wanted to get that number up. So in partnership with a medical student, she and I designed this study to identify ways to improve the referrals to CHWs. So we wanted to, first of all, to identify barriers and facilitators to health-related social need referrals to CHWs. Our hypothesis was that if we know what they are, we can work to remove the barriers, in other words, what's not working, and capitalize on facilitators, so what is working. We also wanted to assess the integration of CHWs within clinical teams because we thought that better integration of CHWs within the clinical teams could improve implementation of the referral process. So this will look similar to the previous study. We did semi-structured interviews with program implementers at multiple levels. So we talked to CHWs, clinicians, and some of our program staff. We used CFR again, but this time we used the updated one from 2022. We did all of our interviews via Zoom between November of last year and February of this year. And then we used a rapid qualitative methodology for analysis. And I'm just going to show you a little bit of our results, just so you can get a flavor of how we organize these into domains, but please don't read everything on this slide. I'm going to highlight a few things. So in terms of the innovation or intervention domain of CFR, one of the things that popped out to us as a barrier was that the referral process may require multiple steps in individuals, right? Like somebody has to hand the patient a screener, the patient has to hand that screener back to somebody has to enter that information into Epic if we're not using tablets, if it's a paper screener. And then that the provider needs to be notified that there's a health-related social need. So there's all these steps that happen, right? And these can be different. So this is why context is so important, is it can be different in one site versus another, because some of our sites have more tech capability and some don't. So in some sites, the referral process required multiple steps and people involved in the process. But then one of the facilitators was a hands-on training for CHW. So we knew that doing hands-on training for CHWs and shadowing could really improve the way that our CHWs function in their sites. In the inner setting, which is really like the context of the clinic site, is how we thought about it in this study. One of the barriers that popped out to us was resident and staff turnover at sites, because Einstein and Montefiore, it's a medical center. We have a lot of residents coming through all the time. So there's a ton of turnover, especially in our outpatient sites, but also in inpatient. And so we know that that can really impact patients, especially those with chronic diseases. But we're also looking at this barrier as an opportunity because we know that CHWs could potentially stand in that gap and maintain continuity of care. One of the facilitators in the inner setting was this idea of having continuous clinician education by CHWs. So our CHWs that were really outgoing, that were always up for like introducing themselves to providers, we saw that as a facilitator for the program. In terms of barriers, we don't have any flexibility with our CHW schedules. Our CHWs are hired by Montefiore and they are unionized. And so they have to work very strict schedules, 8:30 to 5. They punch in, punch out every day. And that can be a barrier when our patients also work strict work hours. And so it's difficult to accommodate sometimes working individuals. And so one of the things we're testing out in the inpatient setting now, because there is more of a standard of having healthcare providers work on weekends and the evening, is having our CHWs do that to see if they can meet patients' needs outside of regular business hours. And then also we know that the clinician plays a crucial role in framing the CHW to that patient. So having that conversation of like, we identified a social need, we can refer you to a CHW. This is how that might be helpful to you. Would you like me to place that referral? And sort of doing more clinician education around how to have that conversation. Finally, in the outer setting, we know one of the barriers is that social service agencies are totally overwhelmed, and everybody knows that. And so maybe providers don't feel like there's any point in referring someone to a CHW who's going to connect them to a service that doesn't even have any good resources. They're kind of disillusioned about this idea, is what they told us. So we know that one of the ways we can respond to that is by highlighting our strong collaborations with community-based organizations and making providers and clinicians feel more secure that when they place a referral, that their patient is going to actually get the need that they're looking for. So some of the next steps for this project, because it's still very much in progress, is we're going to get feedback from our larger group of CHWs and our program staff. We only interviewed a portion of our team, but we're going to do kind of a gut check and make sure that the rest of our CHWs and our team agree with our findings. Then we're going to recruit a group of stakeholders to develop some change processes around our findings. So we're going to identify the important and changeable intervention components, and then we're going to develop some processes to implement and communicate those workflow changes. And then we'll evaluate again to see if those referral percentages have gone up. So just some thoughts about why I think it's so important to assess context in CHW interventions. I think it's especially important given the roles of CHWs. So CHWs are in the field. They're the primary program implementers. They work directly with patients, and they really are the frontline workers. In many cases, they work on their own independently, and they have caseloads of patients or households. Also, our CHWs are situated within the communities where context is always changing. So understanding context is essential because CHWs are implementing programs in contexts that might be shifting as the intervention is being implemented. So for example, right now we're headed into rainy season in Togo. It's the end of dry season and rainy season starting, which means that we're going to have our annual malaria spike. So our CHWs are going to very soon be doing lots more RDTs, rapid diagnostic tests, to check for malaria than at any other time of the year. So they need to be prepared and ready to do that. And so as implementers and their supervisors need to make sure that they have extra tests, that they're sort of looking out for those signs and symptoms, and that they're ready to see how the environmental context is going to change their everyday practice. Similarly, in the Bronx, our CHWs connect patients to health-related social needs to community-based organizations and services, like I mentioned. But eligibility criteria and available resources are always changing. And we want to make sure that patients are never referred to something that doesn't exist or won't work for them or they're not eligible for. So we do a lot of work to make sure we are understanding the context of social services and what's happening in the Bronx to make sure that our CHWs have the right information to give to their patients. Another reason I think this is so important is that it helps us avoid making assumptions. So really, in other words, it's sort of what we think we know versus what is actually happening. So for example, we might think two contexts are very similar. For example, our Community Health Worker Institute just expanded to inpatient care, starting with the Children's Hospital at Montefiore. And while it's the same intervention, same population, we might think like, oh, it's a clinical intervention, it's going to happen the same way. But actually, the context is quite different. So in the hospital setting, our nurses are doing the screening, whereas in the outpatient setting, it's mostly medical assistants and the receptionists that do the screener. And so that's created a very big difference in the two contexts. Also in the hospital, the floors have a different culture. So each floor sort of everybody knows each other. And the 3 floors that we're working on in the Children's Hospital right now, they actually like to have a competition to see like who does the most screens and who does the most referrals. But in our outpatient clinics, they're not geographically close to each other. So they don't necessarily have that kind of physical relationship to have that kind of competition. So the context of outpatient and inpatient is quite different, even in the same health system. And then sometimes you might think that two contexts that are very different, like the Bronx and Togo, have nothing in common, but there are similarities in implementation. A few months ago, we did a research training workshop with our Togo and Bronx teams, and we were talking about how to develop a research question, and each team was asked to identify a barrier to care. And both teams came back, the Togo team and the Bronx team came back separately with the same answer, with transportation. In Togo, they talked about how the rivers flood and they cut across the catchment areas and families can't get to the health center because of the geography. And in the Bronx, they talked about how the highways were developed in such a way that it's really hard to move across the Bronx east to west. And so people have a really hard time getting to medical appointments as well. And so in those two contexts, we had a similar implementation challenge, but very different seemingly contexts. Finally, healthcare. Assessing context can highlight the complexity of the implementation sites and the intervention. So we know healthcare workers are busy, patient appointments are very short, so adding any task can be very overwhelming, but knowing the complexity of the context can help us sort of integrate a new intervention right into the current workflow. Sorry. So in that way, implementation strategies can be designed to fit into the current workflows. So lastly, and I want to make sure we have time for questions, I want to just make a couple comments on this idea of context and generalizability. So this is kind of an ongoing conversation in implementation research. And when we think about context, we think that we see things for what they are. So it can be really easy to impose our own understanding. We might be tempted to think that the way we see things is the truth, but we know that we can't just observe the world and produce knowledge without acknowledging that our beliefs, our values, and our understanding are socially produced and are changeable. So I think that the remedy to this can be formative research and evaluation, and in particular, qualitative and observational work, because it can help us course correct, bringing in perspectives other than our own and helping us really understand the context in which we're working. So rather than assuming that interventions hold the power in of themselves to affect change, if we use a critical realist approach to healthcare research, it can recognize the intertwining between context, which are the elements that make up the setting of the intervention, so the soil that we talked about at the beginning, the mechanisms, which are sort of the unseen forces that trigger change, and the outcomes of an intervention. So a critical realist approach can help us understand research questions about how and why interventions and programs work within the complexities of primary care in any health center. And I think this is sort of the balance that we have to use a lot in implementation science and in behavior change work, is balancing sort of having the perfect fidelity in order to maintain effectiveness of your intervention, but then also tailoring strategies to improve contextual fit. So that's what I had to share with you today. I wanted to make sure you all had my email address, although I think it was on the emails as well. And I'd love to take any questions that you have. So I'm going to stop sharing.
How interesting and wonderful work, Jessica. Thank you so much. I really enjoyed the parallels and how you went back and forth between the two case studies and made those really interesting similarities and differences obvious to us. I also put in the chat that I was excited to reflect on the importance of considering context and that context changes over time. And you talked about something, and I was hoping that you can speak to that a little bit, that context is not only changing over time, but it can be cyclical depending on, weather and other things. So does that define when you are assessing context over time, or did you take that into consideration as you were thinking about the data, the study design?
Right, absolutely. Yeah, so that's one of the limitations, I think, of our work in Togo, because we assessed, we did these interviews 1 year after launch in each site, but we only did it at that 1 year mark. We didn't like go back the following year, which now looking back was an oversight, because I think over time, of course, there can be like some watering down of effects, right? So like maybe 1 year after launch, everybody's really excited about the program. They're like very engaged. They want to do all the components of the program. And then that might sort of fade off eventually, right? So we didn't go back and do that. So I think for us now thinking about doing like sort of a similar type process in the Bronx, I think we are going to do more of that, going back and seeing where things are at. I think, yeah, it's definitely not, I don't think context changes in a linear progression. I think it is definitely like a cyclical thing. And I think also like there's an interplay. So like anytime you insert an intervention, then it changes, it actually can change the context. And then that context is kind of forever changed because of the intervention that you implemented. And then, so you can't go back to zero. So you can never really know what it was like. I mean, unless you did baseline, you know what I mean? So like they interplay with each other and there's an exchange there for sure.
Yeah, no, this is very, very interesting. Let me open it up for others to jump in. Please use the chat or unmute yourself and ask your question.
I have a question. I'm Susan Glockner. I am a family physician and have worked in context, trying to adapt things in context. And did you include clinicians when you were designing your intervention? Because there's some of the things you had problems with that as soon as I heard the design, I was like, oh yeah, that's going to be a problem. And if you're designing an intervention in the future that required the clinicians to be the ones that make that transfer of that transfer to the community health workers, that might be helpful. And just hearing that the Einstein's the context of within primary care versus specialty versus hospitals, just like light years different.
Yeah.
And did you look at the groupings of the acceptance rate by not only by the individual, group, the site, but like collecting primary care clinics versus the specialty clinics versus the hospital? And then one thing that's helpful too is if you find somebody who's an outlier, one of the clinicians who is either really good, and I look at both extremes, ones that it refers a lot versus a little, and find out and do some specific targeting of those outliers. You can sometimes find where some of the squeaky points are. For example, I'll say one thing like, when I was putting an intervention, just having, and do you know what smart phrases are? Where you have a
Oh, yeah.
right? So
Yeah.
we had one clinician was like rocking our intervention, like it was doing great. And we looked at watched her workflow, and she had just put a smart phrase inside of her default visits,
Right.
all the visits that to pop up the screening intervention that was in front of her interface, like hard to miss it. And the ones that weren't didn't use that. And so just by making a smart phrase available for everybody, we improved that a lot. So there's that type of stuff, and a specialty clinic just runs totally differently. And the type of people who are in specialty clinics are just very different. So.
Right. Yeah, so we definitely do use smart phrases. So that's been a thing that we've been using for sure. And the results from what I presented today, that study was just, those 10 sites were all fairly similar to each other. They were all outpatient internal medicine / pediatric sites. But so that paper didn't necessarily look at differences across specialty type, but we are, now that we've had CHWs deployed to the Children's Hospital and also the Cancer Center. That's been really interesting too. I used to work with the Cancer Center a lot in San Diego. And so now working at this one and seeing the CHWs there, it's been really interesting. But I think one of the things that was very surprising to us that I didn't talk about in that paper is we have a clinical champion at each of our sites. And so that's like a clinician who's been part of the intervention from the beginning, from when we developed it, that really helps advocate for us and answer questions and things like that. So we thought that the sites that had clinical champions, not all of them have like active clinical champions. They're supposed to have one, but things happen and somebody moves. So we thought, well, of course, the sites that have clinical champions are going to have really high referral rates. And the ones that don't are not. Not true. Not true at all. Our 3.7% referring site has a clinical champion. Our 68.7% does not. So sometimes what we think are effective implementation strategies, like, oh, this told me in the ERIC strategies list it's going to work, we're going to do it. It doesn't necessarily work. And there's something about the context of those clinics, right? Something's happening there where this site is really not bought in and this site is totally bought in. It doesn't matter that they don't have a clinical champion. So it's like, I know it sounds like so much work to have to talk, but this is part of it, is like having to find out like what is happening in each of these contexts. And then, and actually I have to say that our launch into inpatient care in the fall has gone really well because we learned a lot in the outpatient launch and refined that a lot. And we have like this rock star clinician who's leading the charge at the Children's Hospital, and their screening and referral rates are like in the 90s. And each floor, they, like I said, they compete against each other, they get prizes, and it goes up on all these boards, and it's like a big deal. But also we have nursing is engaged there, and they're all for it, and they want to do the screener, and they, so it also is like leadership buy-in, I think, is such a big component of it too. So, but yeah, those points are really interesting and
yeah,
really
well, in the outpatient setting, you might find that what you need is a medical assistant champion, because as opposed to the physician champion or primary care provider champion, because they do a lot of the paperwork. And the way I've also tried it is show them how it makes them have less work.
Yeah, exactly.
Because then when the patient won't have the callbacks, and they'll actually get their medicines and stuff like that. So if you can show them how, I mean, conceptually, all of us want to help the patients do better, but sometimes you're so overwhelmed when you get added a new task that all you can see is the task you have to do, and you don't see the downstream benefit of that task actually helps you too. And it makes it a little easier to sell with the medical assistants. And they say, oh, well, because you've done this, now the community health worker will have to take that call when the patient calls back, and you don't have to take that call.
Right. Exactly.
And so having that understanding at the the sub-clinician level sometimes makes it go faster.
Yeah, and I think for those of you not working in healthcare necessarily, like I know Anthony, you're on this call. For many years, we worked on a faith-based community-based study for many years. And, we thought, of course, we need the buy-in of the pastor. Turned out, yeah, we needed that. But who we really needed the buy-in from was the church secretary, because she was in charge of the rooms, and we couldn't do our intervention without rooms. We needed space. And so it's like learning about who are the gatekeepers. And you're right, like sometimes we'll assume in a context, it's got to be the most important person. It's got to be the provider. Often the providers are coming in, doing their job, and they're out of there. They're not managing the site. And so you need to get buy-in from the people who are actually in charge of scheduling, and who will give your CHW a desk to sit at, and who will trust them, so anyway.
That's great. Let me see if others have any questions. I did see a request for your qualitative analysis, formative qualitative analysis, a link to that.
Yeah, if they could just email me, I can absolutely respond to that. Yeah.
That's great. And then in terms of using the critical realist approach to healthcare research, I wonder if there are different contexts, mechanisms, and outcomes for different actors. In other words, should actors and their agency be considered separate from context, or should they be considered as part of an overarching context?
Yeah, that's a great question. So I think, and I'm not like an expert in this field, but I think a critical realism stance would say that, you know, there's sort of there's the reality, the truth of what something is, whether or not we're aware of it or not, or have knowledge of it. And then there's sort of our perspective of it. And then within that, in between sort of are like the mechanisms in which help us to see that or understand it. And I think that's where the actors would fall in, is they sort of function as the mechanisms of the context, right? So, but yeah, I don't think you can really separate the actors from the context. They're part of the system. Yeah. I hope that answered your question.
Super. This was wonderful. I don't know if we have a time for another question. If someone would like to do one more quick question, I would think we could do that.
Sure.
And Anthony's reflecting on well, that's a wonderful way to close, perhaps, that they are still going strong with the new iteration of the study.
Yeah, it expanded to in like a dissemination implementation study. So that was really great. That is great that it's happening. Yeah.
Wonderful. Jessica, thank you so much for doing this. We are so
Yeah,
grateful.
of course.
Well, we shared your email address, so please reach out to Jessica with any follow-up questions. And then Kara will be in touch with any follow-up requests for slides or anything else. Thank you for being here. Thank you, everyone. We will see you in June.
Thank you.